in IVF stimulation. Our favorite is to go for antagonist protocol, and recently we have started with PPOS protocol. Just refreshing the physiology that your innate FSH rise starts day 2 or 3 days prior to the menses, and that is why you may start your stimulation with asynchrony itself, and that is why the E2 pre-treatment can have a role either in scheduling or for synchronization of the follicle. So synchronize and to stop this FSH rise over here, or in late luteal phase you can add with the antagonist, and then you can start with your IVF stimulation. So follicular recruitment starts before the onset of menses, and this we have very well discussed. In patients where we have either patients of oncofertility, social egg freezing, endometriosis, poor ovarian reserve, and in our day-to-day practice, what we follow is day 2 means early follicular start of antagonist protocol, where we start HMG, on day 6 we add ANTA, and whenever the trigger criteria is there, we can go ahead with the stimulation. In patients in this subgroup, we don't have that much time because the patient has to go for either chemotherapy, especially in oncofertility, or patient of endometriosis for their further therapy of surgery, or in patients where we have to go for embryo pooling. Then we have either dual stimulation, but in our practice, duo stimulations, back-to-back stimulation we are not practicing because the follicle will take some time for recruitment. So rather than back-to-back duo stim practice, we practice a conventional stimulation protocol where there could be a gap of 15 to 20 days till the time we are having one more follicular wave with good amount of follicles. Then only we start along this protocol for duo stim. Now, I'll first go with long agonist protocol. So this we have not discussed because no longer practicing, but some of the consultants still practice long agonist protocol, specifically in patient with poor ovarian response or endometriosis. Whatever been studies published, there are a lot of comparison between antagonist protocol versus long agonist protocol in patients with endometriosis or poor ovarian reserve. There's like antagonist cycle has better outcome or similar outcome, but compliance wise, antagonist protocol is way better than long agonist protocol, because in long agonist protocol on day 21 of the cycle, so let's say this patient is expecting cycle on 30th of this month, then you will call patient on 23rd, that is 7 days prior to her expected menses. At that time you will give her lupride 0.5 milligram continuously. So now whatever the previous lecture sir has mentioned, now you imagine that you are on day 21, whether you have a corpus luteum. Now this corpus luteum is about to degenerate, where you are having your progesterone and LH on the higher side. You are starting that agonist at that particular time. So you are initially, there could be a flare effect. What this flare effect is going to push, it is going to have more number of follicle push and more number of follicles is going to appear. After 2 to 3 doses, this flare effect is going to go on, and there will be a hypothalamus pituitary ovarian suppression. Now, there is, because of the suppression of the axis, there won't be a innate FSH rise, and you are giving agonist also continuously. Now, with the initial flare effect and your HPO axis suppressed, more number of follicles are there, better synchronization. You wait, you continue the dose of 0.5 milligram till the time the patient gets menses. Now, on day 2 of the menses, no need of measuring of hormonal monitoring. This is, I'm just discussing for the academic reason, that on day 2 what you are going to see, you will be having both ovaries quiet and a good synchrony because your innate FSH rise is not there. LH is less than 5, E2 is less than 60, and endometrium is very thin. Now on day 2 of the stimulation, you start the adequate gonadotropin dose as per the characteristic of the patient, what you have decided. And instead of now 0.5 milligram, you will make the half dose of this agonist, that is 0.25 milligram per day, and you will continue HMG stimulation along with this dose. So your LH is suppressed, but you are giving HMG in your stimulation, that is going to have a follicle recruitment. This follicular recruitment with granular cell proliferation and multiple follicular development is going to give rise to E2. Though E2 is going to increase, but you are giving agonist continuously. So a good LH will be LH will be maintained over a period of time. And then on when you are expecting, what you are expecting on day 7, generally this is also we are not measuring, only for the academic reason. E2 is beyond 300, or E2 beyond 500, we may think that the follicle recruitment is on the higher side, and you may fear of OHSS, because on the day of trigger, when we see that maximum follicles are beyond 70, 17 millimeter, you will give a trigger where estrogen, progesterone on that day you will measure, and you give HC trigger because we don't have any option of giving agonist trigger in long agonist protocol. Only fear again OHSS, because now you have started with very good synchrony and this will maintain. So what is the difference between antagonist and long agonist protocol? In antagonist protocol, you always start with asynchrony because you are starting your cycle on day 2 or day 3 of the cycle. But in agonist, you are suppressing. Now, which patients will be having over suppression, we really don't know. So in agonist long agonist protocol also, that fear of starting with very, very low LH pool is still going to be there, and you may have a less oocyte yield in this particular patient if that patient is having too much of suppression with your long agonist protocol. In antagonist protocol, you will be having a good recruitment on day 6 of the stimulation. But in long agonist protocol, if you observe the lady after 5 days of the stimulation, you may have good number of follicles, but the recruitment is on the lesser side. E2 also will be lesser compared to the antagonist protocol, but the picture will change when it's at trigger day. That time you will be having more herd in agonist protocol because you have more synchrony, and the same situation in antagonist protocol will be different. The oocyte yield compliance wise, antagonist protocol compliance wise is better. The oocyte yield may not suffer in patient with normal responder if we are following the same protocol, but we really don't know in which patient the LH is too suppressed. So now we have moved on from long agonist protocol, we no longer practice. This is just for the discussion sake, we have included that. Now as we were thinking about synchrony, and antagonist is not giving synchrony, then any other protocol when we don't want to go even for E2 treatment, which we can follow, is stop agonist protocol. So stop agonist protocol, as we have started our long agonist protocol from day 21 only, you will give 0.5 milligram of leupride continuously. As soon as the lady gets her menses, then from day 2 of the stimulation, you start gonadotropin, but stop agonist which you had given till that time. It is going to act in the same way that it is suppressing HPO axis, you have better synchronization, and you will start with the high HMG dose. Because why high HMG dose? Because now it is completely suppressed. You want to suddenly have the recruitment. So your FSH threshold, all the follicles should go beyond, and that's why you have start of high HMG dose, maybe 300 IU will be adequate, and then you will add flexible anti in this case, because this agonist effect which is going to be there, it will take some time to have the recruitment of the follicle. So maybe day 6 antagonist is not required. So you can monitor when the follicle is beyond 12 millimeter or 14 millimeter, depending on which patients you are having this stop agonist protocol. Then you can have a flexible antagonist. And then what is the best thing of this protocol? You have a choice of either giving HC trigger or agonist trigger. Let's say even in patient with high responder, you are knowing that this patient is having more than 15 oocyte retrieval at the time of ovum pickup. Instead of giving HC trigger, you can still give agonist trigger, because agonist you have stopped long back, you have stopped it on day 2 or day 3 of the cycle. So that action has wear off, and whether you need antagonist or you need not antagonist, that is on your flexible protocol, whether you really need to add antagonist in this particular cycle. Only drawback of stop agonist protocol, I would like to say that on day 2, before starting the stimulation, do LH level. Sometimes with this 7 dose of leupride, it is too suppressed, and at that particular time, if LH is less than 2, then instead of immediately starting the stimulation, you add estradiol, that Proganova you had add for 3 times a day, give it for 3 to 4 days, again cross check the LH level. When the LH is beyond 2, then you can start with the gonadotropin stimulation, because then you are not suffering with the suboptimal oocyte yield, though you are practicing stop agonist protocol. Ultra long agonist protocol, where in the preceding cycle, means the patient wants to do a cycle in June, and this time you when she gets her first cycle, in the first 3 to 7 days, you will give her leupride depot 3 to 7 days preceding cycle, and on between date 1 to 3 of the cycle. Then that time when she is getting her next cycle, immediately that time E2 will be very, very low, and then you have to start with the stimulation. It will work as your long agonist protocol, again with the same physiology, that you are suppressing it for longer time. Because you are giving leupride depot, it is going to have action of 20 to 25 days. And after all, then you have start stimulation. But leupride injection, as sir was mentioning yesterday, which patient will be having too much suppression, or which patient will get immediate menses within 15 days, very difficult to predict. So this is also a protocol which we are not no longer is following. This whatever sir morning discussed, that on day 2 not required, but E2 and progesterone you can measure. Progesterone mainly if you are looking for fresh embryo transfer. The progesterone on the day of starting stimulation should be less than 1. Then you will go ahead with HMG stimulation on day 6, either a fixed ANTA, or the recent paper what we discussed, we can go for flexible ANTA also. And on the day of trigger, like depending on which trigger you want to measure, you can go for measuring of the trigger, that is E2LH progesterone on the day of trigger, and again post trigger you will be measuring the level. PPOS protocol, in PPOS also you have a fixed day start, that is day 2 of the cycle, you start along with HMG, either meteoric progesterone acetate of 10 milligram or micronized progesterone, or you have a choice of going for dufaston also. Same, you will be giving it continuously and you have both the choices. So initially when PPOS protocol been devised, that time whenever they have given this protocol in patient with high responder, what they observed that after giving agonist trigger, the LH rise post trigger was not that adequate and they had suboptimal oocyte yield in spite of the patient being high responder. So they added 1000 units of HCG on the day of trigger, but obviously risk of OHS is still going to be there. So initially they started adding that, now with the thinking that the suboptimal oocyte yield will be there. But then later on they came with a protocol called PPOS flexi start. So rather than adding the PPOS meteoric progesterone acetate on the first day, we can add as a fixed ANTA on day 6 of the stimulation, or like a flexible PPOS protocol where your E2 is beyond 400 and follicle size is beyond 14 millimeter. Then you add like a antagonist protocol, and then you again have a choice of giving HCG and agonist trigger. And this was a recent study in 2024 that when you are thinking what we learn in trigger lecture, that you delay the interval of giving trigger and your OPU, because there could be a delayed maturity or delayed ovulation in this PPOS protocol. So they came with a nice concept that whenever you are plan to give agonist trigger and you are having a question mark about maturity of the follicle, no need of even delaying that oocyte trigger to oocyte pickup interval. You start ahead with flexible protocol, and they have compared this flexi start of PPOS with standard antagonist protocol, and they found there is no difference with mature oocyte or top quality embryos even if you start flexi start protocol in these particular patients. So you have this choice. This I'm not going to discuss. The one sir was discussing in the morning that let's say we want to, in patients with poor responder, when we think that what protocol will be helpful on day 2 of the cycle, there could not be a good synchrony to start, and we want to have more number of follicles, then we can, instead of planning a duo stim in this particular patient, what we can do from day 2, you give letrozole. When you have a dominant follicle, give agonist trigger. Now with agonist trigger, there will be a flare effect with FSH and LH. The follicle is going to have rupture. Within next 48 hours, there will be a luteal lysis. But the follicular wave which has been generated with your agonist trigger, wait 3-4 days after the trigger, and then you will see a nice herd. And then you start your stimulation in late luteal phase. So you can practice the duo stim in this particular fashion rather than follicular phase 1 retrieval and again in late luteal phase, because that may have impact on the oocyte yield. So in our practice, we don't practice duo stim at all. It is follicle followed by first oocyte retrieval followed by later, and many of our 70% to 80% of our practice is to go for random start rather than doing it on day 2 or day 3 of the cycle. Now whenever we have predicting we could have less oocyte yield, then what we can do, E2 pretreatment is one, but though we really don't know what is the effect of PRP in this particular group, and rather than doing it laparoscopically and that will have additional effect in terms of ovarian rejuvenation. So PRP will work to improve upon the growth factors in the ovary, and that will have push more number of follicles. So whatever study has been published, that is from India only. We really don't know whether it's really going to be helpful with PRP to have more number of oocyte. But what we are practicing, that in first ovum pickup, we counsel that we may have to go 2 cycles of IVF because our numbers are on the lower side. So at the end of first ovum pickup only, we are doing PRP, because now the ovaries are accessible. That won't be accessible unless they are stimulated. Then at the end of ovum pickup, do PRP in both the ovaries. Wait for 15 to 20 days. Whether she gets cycle in between, she doesn't get, that not going to matter. Call her after 20 days, see whether there is a synchrony and good number of follicles, then you can start. Now whether the PRP has worked, or whether you are when you are doing a pickup, that time you are disturbing the hypo signaling of the ovary, and whether that is having additional, that is a question mark. But if at all you want to go for PRP, this is the best way, rather than taking first patient laparoscopy, that will be too costly for patient, and then going for the next cycle. We know that oocyte yield is going to be low and she may need 2 or 3 cycles, so we can practice the intraovarian PRP in this particular way. Now in Jahangir it's not possible, but in Sunanda IVF, what sir additionally do is, on the day of ovum pickup only, he finishes hysteroscopy in patients where there is polyp or there could be thin endometrium he is suspecting on the day of trigger. So rather than it only for diagnostic purpose, so rather than taking again patient for hysteroscopy later on, that is going to increase the time to pregnancy interval for the patient. On the day of ovum pickup only, you can finish off the hysteroscopy if you have hysteroscopy over, and that will save time for the patient. You can additionally cost the patient for that, but patient will be very happy that thoroughly patient has been evaluated at particular time. That time if you are suspecting intrauterine adhesions and she need lateral metroplasty for T-shaped uterus or any other thing, you can always give the explanation patient that we have to again post you, but this will help you in a cost effective way also, and compliance wise is very good. Thank you so much.